So good evening. So almost we have come to the last session of the today's program, that is regarding the thyroid symposium. So for the first sessions, it is a pleasure to introduce Professor R.V. Jayakumar. He is a professor of endocrinology at Amrita Institute of Medical Science, Cochin, and he was also the past professor and head of the department at Medicine, Kottayam Medical College, and he is also was past president of RSSDA and Endocrine Society of India, and he is a alumni of DM Endocrinology from the PG Chandigarh. So I would request Professor R.V. Jayakumar for the reassessing medical therapy in Graves' disease. So after these sessions, we will be having short discussion.
Respected chairpersons and dear friends, at the outset, let me thank the organizers for giving me a chance to come and interact with the later audience. As you know, the topic today is reassessing medical treatment. As you know, many of the people sitting here are day-to-day practicing, managing cases of Graves' disease. I will not be going into the details how to manage a case. I will be only looking at the few aspects of management of disease, like what drug to select, what is the optimal dose of the antithyroid drug, what is the duration of therapy for this condition, and also lastly, which form of treatment is best for Graves' disease. These are the few aspects which I will be touching rather than head to foot. And remember, Graves' disease has got a major aspect, what is called Graves' orbitopathy, which is itself a big topic, so I will not have time to go into that. So if you look at the definition of Graves' disease, it's a condition where it is characterized by diffuse goiter, thyrotoxicosis, infiltratory orbitopathy, and ophthalmopathy, and infiltratory dermopathy. So so if you see in clinical practice, the dermopathy is very rare in this part of the world. So any patient with diffuse goiter and thyrotoxicosis, you make a diagnosis of Graves' disease. That's the usual pattern in this one. So if you look at the genesis, it is due to a TSH receptor antibody acting at the TSH receptor and producing excessive thyroid hormone. I will not be going into the clinical features and diagnosis and differential diagnosis because all of you know about it. So I will be just going into the management of Graves' disease because the topic is reassessment of the Graves' disease management. So as you know, there are three forms of treatment: the surgical treatment, the radioiodine treatment, and also the medical treatment. And if you look at the management of Graves' disease, it is because the hyperthyroidism in Graves' disease is characterized by exacerbations and remissions, unpredictable in onset and duration, and hypothyroidism may occur as a natural part of the end stage of the disease. After initially the patient may have Graves' disease, and later on with treatment and even without treatment, the natural course can land up with hypothyroidism. And medical management is by giving a chemical blockade to the thyroid hormone synthesis and surgery, and you can ablate the thyroid either by surgery or by radioiodine therapy. And these are the usual modes of treatment. Now, the drugs which are available, antithyroid drugs, are carbimazole, methimazole, which is the metabolite of carbimazole, and PTU, or propylthiouracil, are the three drugs which is available in the Indian continent. And all these block the thyroid hormone synthesis, and all may enhance the remission through their anti-immune effect. And PTU has got the added advantage of inhibiting the peripheral conversion of T4 to T3. But both drugs do not block the release of the preformed hormones. So euthyroidism do not occur until the stores of the hormones are depleted, and it may take from any time from 1 to 6 weeks. And no definite guidelines for the duration of treatment of these drugs, but usually all the textbook says that you give treatment for about 12 to 18 months. And remember, the most important thing of antithyroid drugs compared to the other forms of therapy is that the antithyroid drugs have exert powerful beneficial immunosuppressive effect, and Graves' disease and immunomodulatory disorder, and so antithyroid drugs have got a plus point in because it controls it has got a immunosuppressive effect also. And if you look at the medical management, Usually the thionamide treatment, either carbimazole or methimazole, is about 30 to 40 milligram. You start with it, and if it is PTU, you got to go for 300 to 400 milligram till the toxicity is controlled, and then you maintain at a low dose for about 12 to 18 months. And the dose maintenance is derived by back titration every 6 to 8 weeks on the basis of TFTs. But one study, there are a few studies, has shown that there is no difference if you give 10 milligram of methimazole or 40 milligram of methimazole. One study has shown that in 93 that whether you give 10 or 40 milligram, at the end of the 6 weeks, both of them achieve the reasonable euthyroid status. Even studies from India and a personal experience from all the institute and all those things we hear in all conferences, there is no meaning in going above a dose of carbimazole of 30 milligram, because there is no need to give 40 or 50 or 60 because the effect plateaus off. So what you get by 30 milligram, you give it, it will take at least 6 weeks for the thyroid state to become euthyroid, and there is no added advantage. But even then there is a personal difference is there. So the duration, there is a place for comparatively moderate dose, about 30 milligram of carbimazole for starting treatment. Now, there is a treatment called block and replacement regime, and administration of fixed dose of thionamide with thyroxine to prevent iatrogenic hypothyroidism. What in this method, what they do is you start with thionamide. By the time after 6 weeks, by the time you expect the euthyroid state to occur, you add a 50 to 100 microgram of thyroxine also, so that the chance of going to hypothyroidism is prevented. And studies have shown that this regime, especially in the Japanese continent, they have found that it is the chance of remission of Graves' disease if you add this block and replacement therapy is better compared to giving only thionamide. But the only thing is, the advantage is that you need only testing only once in a way, not a regular testing if you give both, because the chance of getting hypothyroidism is less. But others are unable to reproduce the effect of less remission with this block and replacement therapy. But remember, don't play with this regime, block and replacement during pregnancy and thyroid, because in pregnancy if you block, then naturally you will have to give higher dose of thionamide, which will pass the placental barrier and go to the fetus and produce problem. So there are minor side effects for the antithyroid drugs. 1 to 8% of patients include pruritus, rash, urticaria, arthralgia. And serious side effects of thionamides are agranulocytosis and toxic hepatitis. The agranulocytosis is rare, 2 to 3 in 1,000 patients treated, seen with both carbimazole and propyl thiouracil. Usually seen in the first 3 to 4 months, but it can occur any time of treatment. And so agranulocytosis occurs so suddenly, so even a weekly blood count is not going to prevent it or going to give a clue that it is going to occur. So there is no meaning in asking the patient to do periodic blood counts when the patient is on thionamide, because it can come all of a sudden. So only tell the patient when they give a sore throat or a fever or immediately do a blood count and contact the physician. So this is the other thing, the hepatotoxicity which has been brought right recently, that is PTO has been associated with fulminant hepatic necrosis, and it is the third most common cause of drug-related liver failure, accounting for 10% of entire drug-related liver transplantations. Even if you look at the third, drug-induced hepatic necrosis, it is the third most common cause, and it is responsible for 10% of liver transplantation. So such a severe hepatotoxicity can occur with PTO, so which has led to the associations like American Thyroid Association, Clinical Endocrinology Society to advise to use PTO only during the first 3 months of pregnancy, otherwise in all other situations don't. So coming to the choice of antithyroid drug, which drug to use, you have got this. So the efficacy of carbimazole and PTO thought to be almost same, and but one study showed that 15 milligram of methimazole was much more effective than 150 milligram of PTO in achieving euthyroid status. And another study showed that thyroid functions improve more rapidly with methimazole compared to PTU, all putting a plus point for methimazole, carbimazole rather than PTU, or because it is faster and is more efficacious, some studies. So making a choice between them was only a matter of personal difference till recently, when Because due to this associated hepatotoxicity, ATA and the American Association of Clinical Endocrinologists recently recommended that PTU should be only used in the first trimester of pregnancy and in case of drug allergy to carbimazole, and all other situations you must use methimazole or carbimazole. So that leaves us the choice of selection on the basis of this recommendation that we will be using in majority of cases methimazole or carbimazole. Now, the main disadvantage of medical treatment is high relapse rate after stopping the drugs. Around 50% relapse is seen. No test will separate those patients who will relapse from those who will not. And large goiter, HLA, DR3, thyroid stimulating antibody titer, T3, T4 ratio, some people say high T3, T4 ratio, T cell subset ratio, all may be able to predict it, but in clinical practice it is not going to be useful because you cannot do HLA, DR3 in all your patients or T cell subset ratio and all. And some people claim that a large goiter with there is a higher chance of recurrence, go for a more definite form of treatment. But the duration is that 40, see even the 40 to 45% people who are treated with medical drug, everybody agrees they can remain in remission so the relapse after a full course, so the usual teaching is go for a definite form of treatment like surgery or radioiodine therapy if somebody relapses after 18 months. But I think that trend is, so it is a duration. So one study showed that if you give 6 months regime, there is a 31% relapse. If you increase it to 2-year duration, it is 82%. Now we have to think that whether if you give lifelong, what is it? Is it going to be 100% or not? Let us look into the studies about this. So prolonged medical treatment. According to the experience of many Indian endocrinologists, there are patients who are well controlled on prolonged low dose carbimazole, methimazole therapy for years without any problems, even though none of the textbook says that you should give it a long term. Many of them are on this prolonged therapy as they are not happy to undergo surgery, and radioactive ablation is not freely available in this country. So it depends upon the, but if you want to give long-term therapy, the patient must be compliant and must come for for follow-up and with a T4 TSH testing at least once in 6 months. And let's look into the literature for about this prolonged therapy. There were 193 articles indexed on long-term antithyroid drug therapy, of which 8 were for more than 10-year duration. And of these, 3 were randomized clinical trials between methimazole therapy and radioiodine therapy. Others were cohort studies and case control studies. So 3 controls randomized trial comparing the efficacy of long-term antithyroid drugs with the radioiodine is available in the literature. And the latest trial consists of 239 patients followed for a mean period of 14 years. It has been published 2 years ago. And the methimazole group has a better BMD. They looked into all the aspects of this. The methimazole group had a better BMD, better score in neuropsychiatric tests, and had less incidence of subclinical hypothyroidism compared to the radioiodine group, because as you expect, radioiodine therapy produces majority hypothyroidism. So it is no wonder, but it is possible without any side effects to have long-term for 16 years and 18 years of therapy with antithyroid drugs. So the other medical treatment is iodine and iodine-containing drugs, because it is used in the management of thyroid storm mainly and preparing patients for thyroid surgery. Beta blockers, again, to buy time when before the effect of antithyroid is effective. Beta blockers help to ameliorate the symptoms and appear faster than thionamide, useful in the early phase of treatment. And those cases which cannot tolerate antithyroid drugs, you can use it alone as a preparation or pre-operative or a pre-radioiodine treatment. What is the role of corticosteroids in the management of Graves' disease? Glucocorticoids inhibit the conversion of T4 to T3. In Graves' disease, steroids may decrease the T4 production by immune suppression also, and use is restricted for thyroid storm and Graves' ophthalmopathy. So coming to what is the role of antithyroid drugs in pregnancy, Graves' disease presenting during pregnancy is treated with antithyroid drugs, occasionally by surgery and never by radioiodine therapy. Treatment is by, when you treat a patient with pregnant lady with Graves' disease with antithyroid drugs, the main point remember is treat with the minimum dose. Just to control the symptoms. Don't try to achieve a biochemical cure for this patient. And PTU due to its increased protein binding and less crossing the placenta is the best drug in the first trimester. And antithyroid drugs are not contraindicated in pregnancy, and pregnancy is not contraindicated in women with the Graves' disease who are taking antithyroid drugs. So if you, previous teaching is that if you have a patient with Graves' disease on treatment, do some form of permanent form of therapy before you advise them to have a child. But nowadays they say even on drugs we can have a baby. The drug should be titrated to the lowest possible dose, and the block and replacement therapy should not be used. So Graves' disease in children, medical treatment is the usual one. Surgery is indicated with those who relapses. I-131 ablation is usually not the first choice of treatment in our part of the world, but in America it is very popular, even in children. And recently studies have come out saying that long-term treatment of carbidopa therapy for more than 10 years is very effective in children, provided the compliance is good and they come for regular follow-up. So what is new in the pipeline for this? See, rituximab is a monoclonal chimeric human mouse antibody directed against CD20, and this drug was used in Graves' ophthalmopathy, and it was found to be useful. But the two studies show that it has lesser effect on hyperthyroidism, but in another study Graves' remission was also, it was useful. So other hybrid molecules which act through immunomodulatory mechanisms are also being used. So lastly, which form of therapy you should give? Antithyroid drugs in Graves' disease. So which form of treatment? It all depends upon where you are working. Selection of treatment depends upon so many, who is running the thyroid clinic. Is it the endocrinologist, surgeon or nuclear medicine specialist? And what nationality you are? Are you a Japanese, are you American or a British? It all depends on it. And what are the facilities available at it? Because why I said so? Because Japanese consider radioiodine treatment as inferior to other form of therapy because the nuclear blast. But in America it is other way around. In 1990s the US President Senior Bush was given radioiodine treatment for this Graves' disease. So do you think that Americans will give a second-class treatment to their president? I think majority will say yes, but I personally have my own doubt because American, I think personally the Indian brains are much more better than Americans. So the take-home message is antithyroid drugs are safe and effective, useful in children, PTU, I think. Okay. Treating one disease is not at the expense of the other. Last take-home message is that treating one disease should be not at the expense of creating another disease, because radioiodine therapy produces hypothyroidism we are treating, whereas medical treatment keeps the patient euthyroid. And lastly, we as endocrinologists should popularize our brand of therapy, that is a medical treatment, rather than advising other forms of treatment to our patients. Thanking you. And lastly, I welcome one and all of you to attend this big thyroid conference which is going to take place in Kochi. That is the Asia Oceanic Association of Thyroid Conference.
Thank you, sir. Actually, we have overshot the time. We have time for one or two short questions.
What is the maintenance dose, sir, in these patients after completing the treatment?
Maintenance dose.
Maintenance dose is a smaller one. Usually it all varies depending upon the T4 and TSH. And I have found my patients, some of them requiring only 5 milligram maintenance, some requiring 10 and 15 milligrams. It varies from anything between 5 to 15.
Yes, sir. Yes, sir.
Dr. Jayakumar, you had extensively reviewed the literature. I have a very basic question to ask you. Nowadays, all over the world, people consume iodized salt. What are the instructions given to the patients with Graves' disease? In many of the studies, do you see any instructions regarding iodine intake?
I think the only thing is, if you have got a patient with Graves' disease, you find it very difficult to control, then cut short the iodine intake. Otherwise, we are all supposed to be taking, we as Indians are supposed to be taking iodized salt. So we have an area. So iodized salt should not be given to patients with Graves' disease whom you find it very difficult to control. But if the patient can be very well controlled with the usual standard drug therapy, there is no indication to stop iodide intake.
From my experience, I would say, if you stop iodized salt intake for these people from day one, the remission rate is quicker and longer, and you'll have more number of people who go into remission.
Thank you, sir. One last question.
Last year, thyrotoxic patients have associated bone disease. I am Dinesh Thanwal from New Delhi, so I think I'll suggest that we should also give vitamin D, not with calcium, because some of these patients can have hypercalcemia. Some of the studies we have shown that majority of patients, in fact much more than normal population, they have vitamin D deficiency. And secondly, in the intervention trial, we have also shown that if we give vitamin D alone, 60,000 once a month, we can prevent osteoporosis in these patients. So I think that also we can start using. Thank you.
I think I fully agree with it, because not only if the patient is having Graves' disease, even without Graves' disease, today morning discussion, everybody agrees that a physiological replacement of vitamin D is good for one and all, because all the studies have shown the Indians have a lower level.
Okay.
Yes, I happen to be in the field for about more than 30 years, and I have come across only one case. I was lucky in that. I don't know whether Dr. Kannan, one or two cases, I think 2 cases only.
I have yet to come across a case.
Yeah, thank you very much, sir.
Sir, one question, madam. In my experience, I have seen many of type 2 diabetes people are suffering with hypothyroidism also, not hyperthyroidism. Yeah, that's the thing I'm telling you. Only. Just one question. So majority of these cases are going with hypothyroidism rather than hyperthyroidism. In such a cases, how long you have to treat that until to achieve euthyroidism or lifelong?
I'm sorry, sir. I think it's beyond the purview of the topic. You can discuss it personally with Jayakumar, sir, later. We'll move on to the next session for lack of time. Thank you, sir, for this session. And